Our next speaker, we've changed the order for the next two talks. I'm delighted to invite Karen Horvath to speak to us on how I plan to incorporate FES into my residency training program. Dr. Horvath is Professor of Surgery and Program Director of Surgical Training at the University of Washington in Seattle, and I'm delighted that she's here to speak to us.
Thank you very much, Jerry. Thank you to SAGES for inviting me to speak to you all today. This is actually a little bit more of I think, a personalized approach, since it's how we plan to do it at our place. But I'm hoping that this will kind of give you some ideas about how you might want to apply this in your own programs. And I do want to just ask you to pardon me. I have acquired a cold, and I'm going to try not to let that affect my presentation too much, but I have no disclosures. And again, I think that what I'd like to do with you today is just take you on a walking tour of how we approach the FES question at University of Washington in terms of why, where, what, when, and the challenges, I think, inherent in bringing FES into your residency program. So why do we want to implement FES in our residency program now? And I think that the reasons are three. First of all, first and foremost in any of our discussions are our patients. As we've learned today from a number of the other speakers, general surgeons need endoscopic skills, not only for the evaluation and treatment of GI diseases, but for to serve the needs of the rural and underserved areas of our country, and is shown in a number of other studies in use in the global health field. I think program directors we're always very, very concerned about RRC accreditation of our program through the ACGME. And as you saw from Dr. Mellinger, that we do have endoscopic case requirements. And with some new political barriers that we're facing, it is difficult for some programs to get numbers. I think this is the second reason for why to do it is maybe a little bit on the softer side, and it may even be a little bit idealistic of me, but I think that implementation of FES into our residency programs and training our residents to a level of proficiency prior to that rotation may actually help to break down some of the barriers. And finally, I think that another thing that we residency directors are always looking forward into the future for is, what is the American Board of Surgery going to require as a certification process, and do we need to kind of jump the gun and be ready for that? And I think that one of the things that we program directors are thinking about is that that FES certification, kind of like FLS certification, is probably going to be mandated by the ABS. And so those are the reasons why we're doing it. Why we're not implementing FES. I think FES is not going to help future graduates with credentialing or hospital privileging, and it is not going to replace any of the clinical experience and endoscopy case numbers required. The residents are still going to need the GI rotation. So a little bit about our situation at the University of Washington. So where are we going to do it? We have a simulation center called ISIS, and that is the place where we're going to implement FES. Our simulation center, a little bit some details about our setup. We have a receptionist and lab technicians that are available for course setup. We also have a director of resident technical skills at education, Dr. Andrew Wright, but all of our other faculty members are volunteers. And unlike UT Southwestern's, where they have these skills lab coaches that Dr. Scott mentioned, we do not have any skills lab coaches or other non-faculty teaching personnel. And so we are very much reliant on our volunteer faculty. We also have a mandatory technical skills rotation, and this is called an EVATS rotation. We've actually published on this separately, and it's a rotation that's done at each level of the residency training program. And during that time, residents have some dedicated time and protected time in the skills lab to go through and complete technical skills portfolios. And I'm going to show you just one excerpt of that in a second. And the idea that we kind of pervades our resident technical skills education at the University of Washington is that whenever possible, we like to do simulation training before it's required in clinical use. So I told you that I was going to show you a little excerpt of what one of our resident skills portfolio looks like. This is just one of, say, maybe 4 pages. So you can see that, and this is for the R2 level, that when the R2 goes into this EVATS rotation, that they're required to kind of go through a number of different steps. And you can see that right now we do have our residents doing some training on the GI mentor, and this is the place that we would plan to insert the FES curriculum into our curriculum. So what are the FES components and what are our training goals? I think this is actually an important question because it's determined for us where we're going to insert the FES, the different components of the curriculum and the assessment into our residency program. So residency directors, we are often thinking in terms of training and assessment, or training and evaluation. In terms of the flexible endoscopy curriculum for our residents, FES has a web-based FES didactic curriculum component, and then the other training aspect is using simulators to train endoscopic skills. Right, we actually are fortunate to have a Symbionics GI mentor at the University of Washington, which our residents use. But there are also some desktop training modules, which are, I think, coming very soon, and other simulation trainers to train for flexible endoscopy. And then certainly in terms of the training component, certainly we have the GI rotation where they do the actual get their cases and get their clinical skills. In terms of formal evaluation and FES certification, there's the multiple choice cognitive FES exam, which I think Dr. Vasilio is going to talk to you about, and the hands-on FES skills test on the GI mentor. Both of these have been validated. And then there's the gauges, or the global assessment of GI endoscopic skills, which is also an assessment, but is separate from the FES formal exam. And I'm going to show you how we plan to kind of incorporate all of these. So again, I think in terms of deciding where and how, I think it's important for us to talk about what our training goals were for our program. So first of all, we want to improve patient care in our training program, and we want to train our general surgery residents to be as proficient as possible, as quickly as possible, and I think very importantly, to get the most out of their clinical GI rotation and hit the ground running. And this was really I would say the major component and how we decided when in the program we were going to implement our FES. So again, this comes down to before, during, or after the GI rotation. I spoke with Dr. Jeff Marks, one of the kind of key developers of the FES curriculum in preparation for this talk, and we talked a little bit about how the FES testing and evaluation was actually designed to work. And it was actually designed, and this is basically a disclaimer, it's the FES is designed to test after the GI rotation. And so so I do want to acknowledge that was the intent. However, we are actually, Dr. Wright and I have decided that we're going to actually implement FES pre-GI rotation. Again, because the philosophy that we have in our program is to pre-train before clinical experience. And so the way that we're going to start with FES implementation is we're going to have our residents complete the FES online cognitive curriculum and skills curriculum on the GI Mentor and train to proficiency level, and then implement the FES certification test followed by the GI rotation. And while they're on the GI rotation, we'll ask them to complete a GAGES clinical skills assessment test. And you can see that I have a little cartoon of a person kind of walking towards a cliff. We don't really know if this is going to work, but this is kind of what we're thinking right now. This is basically telling you what I just told you, but just looking at it pictorially in a different way. So again, during our residents' PGY2 year, they'll complete the FES online cognitive curriculum. They'll train on the GI Mentor to proficiency, take the FES test, and then do their GI rotation. I think the big question mark is whether or not we're going to have to move the FES test to post-GI rotation, and we don't know. I think that we may need to try out this initial plan, but we may need to rethink it after its first year of implementation, especially if all of our residents fail the FES tests and need to retake it. And I think we're obviously going to say that our idea is not successful and we'll need to redo it. So I think our challenges to implementing the FES, I think it's important to talk about those, is I talked to you a little bit about the availability of skills lab coaches, which we don't have any at our place, and our faculty are not available 24/7 in the skills lab. And I think that it is I want to tell you a little story to highlight that supervision is very much required for all simulators, not only endoscopy, but we had when we got our GI Mentor simulator a year or two ago, we had a very, very self-motivated R2 who was doing his research years. This is a technically excellent, very highly intelligent, very highly capable resident. And he, on his own, went and completed all of the GI Mentor modules. And however, he taught himself using the wrong hand and holding the scope in his right hand versus his left. He met all of the proficiency metrics on the GI Mentor and met all the benchmarks. And then, of course, he came back into the clinical arena and went to his GI rotation where they let him know that he was using the wrong hand. So I think in addition to having appropriate supervision, there are some time limitations. I think that simulation training time competes for other very important residency training requirements, and that's constantly what program directors are juggling with. Also, our faculty participation is declining, and I think that the idea of having promotion credit to allure or entice faculty to into the skills lab to help out is really what we've found is that it's been a very lukewarm motivator, unfortunately. I think there are some cost limitations. We do have a need for these skills lab coaches or non-faculty training personnel. I think that the simulator cost can be prohibitive to many residency programs around the country. The GI Mentor costs about $80,000, and again, this is going to be prohibitive for many programs. And then there's although the cost of the FES examination is not really that great, when you add on to that just a little bit here and a little bit there, so we have to pay for the ABS, the ABSITE exams, and the ATLS exam, and then now the FLS exam, which currently is covered by COVIDian vouchers, but may not in the future. But you add all of these things up, and the cost is kind of creeping upward. And I think that there are other tools that our residents need as well. Finally, I think that one of the things that we need to find a way to do is to find a way to resource share regionally. So, for instance, there are 3 other surgical residencies in the Seattle area, and how can we best resource share not only our lab and our simulators, but also space, faculty time, and their involvement. So in summary, we at the University of Washington, we're going to implement FES because patients need surgeons with endoscopic skills, and we believe that FES will augment the clinical experience. And those are the two most important reasons. The third reason is probably it's going to be required by the American Board of Surgery, and we're going to have to regardless. I think FES implementation, it's going to occur in our simulation center during our technical skills rotation on our Symbionics GI mentor. And since our goals are to pre-train in simulation before clinical experience whenever possible, we're going to implement the FES training and testing being the R2 year prior to the R3 GI rotation. And I'd like to thank SAGES and my moderators once again for inviting me. Thank you very much.